Good afternoon. My name is Adrian Dix. I'm BC's Minister of Health. To my right is Dr. Bonnie Henry, BC's Provincial Health Officer. This is our COVID-19 briefing for British Columbia for Thursday, March the 4th. We're honored to be here on the territory of the Lekwungen-speaking people of the Songhees and the Esquimalt First Nations. Tomorrow, Friday, at around 3 o'clock, we'll be providing a written briefing with relevant information, including case numbers for COVID-19 in British Columbia. And next Monday, we'll be back here in the press theater here in Victoria to provide an in-person briefing. Next week, later that week, Dr. Henry will be updating some of the modeling and updating the course of the pandemic in British Columbia next week around the time of the first anniversary of the declaration of the pandemic. So that's what you can look forward to in the next week in terms of briefing. And with that, it's my honor to introduce Dr. Bonnie Henry.
Thank you and good afternoon. To start with today, we have an additional 564 new cases of COVID-19 reported in the province, including 12 epidemiologically linked cases, bringing the total number of people in British Columbia with COVID-19 to 82,473. Of those, 168 are in the people in the Vancouver Coastal Health Region, 279 people are in the Fraser Health Region, 35 people are on Vancouver Island Health, 36 people live in the Interior Health Region, and 46 people live in the Northern Health Region. We now have 4,743 active cases across British Columbia, of whom 248 are in hospital, 63 in critical care or ICU. And we have 8,659 under active public health monitoring. And on the positive side, 76,289 people are now recovered. We've had 4 additional deaths in the last day from COVID-19, bringing our total to 1,376 people in our province who have succumbed to the virus. And our condolences go out to our families, care providers, and our communities who have lost loved ones during this most difficult time. We have no new outbreaks to report today, and we have 7 outbreaks in long-term care and assisted living, 3 now in independent living with very small numbers, thankfully, on those, and 8 outbreaks in acute care settings. We have those involve the long-term care and assisted living involve 269 residents and 131 staff. Oops. I'm missing one of my notes around, there we go. As you know, we are following quite closely the variants of concern that are rising in the province and across Canada. And we've had an increase today of 46 new confirmed COVID-19 cases that are variants of concern. So that brings the total to 246 that we know about in the province. Of these, 16 cases are still active, and the remaining are people who have had past cases. 218 are the B117, which is associated initially with the UK, and 28 are the B1351, which is initially associated with South Africa. The majority of these variants of concern continue to be in the Fraser Health and Vancouver Coastal regions, 178 people in the Fraser Health region and 60 in the Vancouver Coastal Health region. There continue to be just the same small number, 6 on Island Health and 2 people in Interior Health, and no confirmed variant cases yet in Northern Health. As you know, we are most concerned as well about transmissibility and where people are becoming infected with variants of concern. And right now we continue to have challenges in identifying the transmission chains for about 25% of our cases. There are currently 4 people in hospital, and 2 of the deaths that we've had in recent days have been people who had been infected with a variant of concern. As you know as well, since the start of our immunization program, we're almost at 300,000. We're 298,851 doses of vaccine have been administered across BC, and the number of second doses is about 86,746. And as you know, we made the very important decision as more data was becoming available earlier this week to increase the interval between the first and second dose so that we can maximize that really good protection that we're coming to understand that we would get from the initial dose of vaccines in BC. And I do want to acknowledge that this decision-making that we made, particularly around the extending of this interval, as we've had in a number of cases, reflects us learning as we go through this pandemic. We've learned about how the virus transmits. We learned about how are the measures that, where it's most likely to transmit, the measures that we need to take to protect each other from transmission. And as these vaccines have become available, almost day by day, but definitely by week, we are learning more about how they work, about their effectiveness, about their safety, which is also critically important. And the decision making that we don't take lightly. We spent quite a lot of time looking at it, but we did need to take this decision rather rapidly over this weekend after extensive consultation, because we were coming up to a time this week where there was tens of thousands of doses of vaccine being scheduled for people to receive their second dose, and that would have left us with very little vaccine to be able to continue our need to protect more people in more communities around the province. So while I will regret and apologize to those communities, to the long-term care homes, and to individuals who had a second dose scheduled that had been postponed or for several months now. And I know that came as a shock for many people. And I regret that our communications weren't able to keep up as fast as the decision making. But please know that this was made in the spirit of understanding data and maximizing the benefit to all of us. And that dose you didn't receive on Tuesday or Wednesday or today is now being administered to a community member, to another member of our family, our community here in BC, to protect them. And ultimately, it will bring us all closer to getting to our post-pandemic world. Also want to address the fact that the National Advisory Committee on Immunization has also endorsed that this is the right thing for us to do in Canada right now. And I want to express my gratitude to NACI. NACI is an amazing group of experts. I've had the privilege of sitting on the National Advisory Committee for 8 years. Some of our colleagues here in BC, our best brains around immunization, have also been both members and chairs of NACI, and we tremendously respect the work that they do, and we're just very grateful that we have all come up with the same important decisions around these critical issues for us in BC and in Canada. As you will also know, the first deliveries of the AstraZeneca Serum Institute of India COVID-19 vaccines will be arriving in our province, we expect sometime next week. This vaccine will be made available to first responders and other essential workers, and the delivery of these vaccines will run in parallel, but separately from our age-based community-wide immunization program. And when I say that, we had in our initial plans, it was looking at phase 3 and 4, because that's what we understood these vaccines would be available. So it is an added bonus to us that we now have these vaccines earlier in this program. But I also recognize that the category we're talking about, first responders, essential workers, is a very broad group of people. And we have come to recognize through this pandemic how many people absolutely are essential workers, or people who cannot work from home. And we know that that covers a broad swath of people. So as we have done with our immunization so far, we will prioritize our delivery of these vaccines accordingly. And I want to be clear, this is not a random process. This is not me making a decision out of the blue. We follow a very defined process. And I referred initially to NACI, the National Advisory Committee on Immunization. Earlier on, when this pandemic started, we all went through a process of determining who vaccines could be available to, who would be the priority populations if and when vaccine became available. And those lists, those categories have been refined and revised over the period of the last 10 months. And since we've had vaccines available, they've been revised again. Early on, we didn't know if vaccines would be effective in older people, as many other vaccines are less effective. But we now know that they do work, and they work very well in older people. They work well in people with chronic illnesses. They work well in many populations. So that's allowed us to monitor and change things a little bit in terms of that. And here in BC, we have a long-standing BC Immunization Committee that is also made up of experts from public health, from vaccinology, the Vaccine Evaluation Centre. We have pharmacists and family doctors and infectious disease specialists and others who have sat on this committee for many years. It rotates periodically, and it's supported by the BC Centre for Disease Control. And so our recommendations around who gets vaccine when are based on using the NACI guidance, looking at the data in the real world, and the analysis that's done by our standing committee, the BC Immunization Committee, which is our provincial level equivalent. And this committee uses public health, both the immunology, vaccinology, vaccine science, and public health principles, as well as an ethical framework. And I would refer people to the BC CDC website, where we have our ethical framework for decision making around vaccines as well posted. So based on this information, we will, the BC Immunization Committee is right now going through a process of defining who should receive vaccine when, as it becomes available, and that we will ensure that those groups are then sequenced and we put the operational pieces into place. So those recommendations I expect are coming to me in the coming days, and based on this information, a detailed plan will be developed over the next week to 2 weeks, which we will share publicly as soon as we have those details ready, and I'm hoping and expecting that will be around the 18th of March. In the meantime, we are planning to use the initial shipment of the AstraZeneca vaccines, the Serum Institute of India vaccines that are coming available as soon as we can, to address our ongoing clusters in outbreaks that are leading to some of these rapidly increasing numbers in some places, some communities, to best protect our communities. So we know that there are some outbreaks right now that have been going on, that have been challenging to manage, where immunization is going to be that extra tool to help us manage those, so that we can stop that cycle of workplace to community transmission. And that will be our focus initially. So also today, I wanted to bring us up to date on something that we've also talked about quite a few times over the last number of months, and that's our strategy and our plan for use of point-of-care testing. So part of our response, we are using these rapid tests as another tool to support public health contact tracing and outbreak response efforts. And we have a strategy that has developed and evolving since we started to receive these tests early November of 2020. So there's a couple of things that we need to sort out. When we talk about rapid testing and point-of-care testing, we do have some PCR. So PCR is the lab-based testing. It's our gold standard. It's the one that we use for a diagnostic test for COVID-19. It's high sensitivity, so it's the most accurate of the tests that we have. And we do have some machines that are able to be used in smaller settings that are outside of a laboratory. So they're called Gene Expert or BioFire machines. And we received some of those earlier on. We had a few here in BC already that we repurposed to be able to put in smaller communities. And the whole purpose of that was try to reduce the turnaround time from when somebody got a test to when they got the results. And we report on turnaround times. And for PCR testing, the turnaround time now is less than 24 hours in most places. But in some communities, the travel time to get even to one of these point of care PCR tests can mean that there's a delay of a day or two. And this is where rapid testing can come in to fill a gap. So when we're talking about these rapid tests, the point of care rapid tests, we're talking about two types of tests that have come into BC. One of them we call a RAT, which is the rapid antigen test. So it looks for the antigen in the swab, and it's what we call it a laminar flow test. So that's the little ticket test. Right now, those still require either a nasal pharyngeal or a nasal swab. So you have to stick the swab up your nose. It can't yet be used with the swish and gargle and spit test. Those ones we use in places where you can do multiple people at a time. The other one that we've had in Canada that we started to receive in November was nucleic acid amplification tests, so RNATs. And these ones are more sensitive, they're a little bit more accurate, but they also require a nasal pharyngeal swab, initially nasal pharyngeal swab. Very recently we've got anterior nasal swabs. Those were only approved for use a few weeks ago. But these ones require a machine. It's a small portable machine, and it can only do one test at a time, and that's important to remember as well. All of these tests take about 15 to 20 minutes. So in October last year, when Government of Canada began to approve these point-of-care testings, we started to receive them at the end of October and into November. It's important to recognize, though, that there is a step that needs to be taken when these are shipped out to validate each lot of tests. And we do this for many things. It's a quality assurance process to make sure they work as they're supposed to. And that validation process could not be done in the scale that it needed to be done by the federal government. So we were required to do that here in BC. So we did that as rapidly as possible through the BC CDC, the St. Paul's Laboratory, and those tests were validated mostly in November and into December. Since that time, we've done 39 pilot projects across BC about where these tests can be used to try and determine where their best use is. We've used them in settings from long-term care facilities, rural and remote settings, so times when that turnaround time to get the more accurate test takes too long in our provincial correctional facilities. We've used them in a number of different situations to manage or to assess outbreaks in workplaces where we've had a number of workers who are positive. It allows us to rapidly assess the scope of how many people might be affected and to supplement it with PCR testing. We've been using it as well to help us understand whether there's been transmission from the variants of concern in school settings. So we did that, and the first time we used it was in Garibaldi High School, where all of the cohort who were infected, we used both the point of care testing, the rapid test, to understand anybody who might be infected at that time, but we also had to use the PCR test so that we could understand the accuracy of the rapid test. So we've also used it several times in schools when it will change management. And this is the principles that we are using these tests. They supplement the other measures that are in place, and they help us to understand when we need to do things rapidly. And there's two situations that we use them. One is when for testing of people with symptoms to determine whether they might have COVID or something else. This has been very helpful in situations where people have had a test 3 days before and they go for surgery, and the day of their surgery they have a bit of a cough or a bit of a runny nose. So a rapid test in that situation can help us know whether it's safe to continue with that surgery, and those are some of the situations we've been using here. We use it for testing of people in the downtown east side, for example, people in congregate living settings, when it's hard to tell if the symptoms they're experiencing are from COVID or from withdrawal symptoms. So they have been quite effective in those situations. The second place that we are using point of care or rapid tests are in people who do not have symptoms. And it is in that situation that it is more challenging to understand where the role of these tests is. We have been using it in a number of long-term care homes to screen healthcare workers when they come into work who don't have symptoms, to see if they may have COVID-19, asymptomatic shedding. And we've done that in 7 different long-term care homes so far. Of the thousands of tests that have been done, 2 of them have been positive. And both of those cases were in facilities that were having an outbreak. So what this tells us is that when the background level is higher, your probability of picking up somebody who has an asymptomatic infection that doesn't have any symptoms goes up, and that they're not as useful in areas where the background levels are low. So if our community transmission rates are low, screening with these less sensitive tests is not very effective. It doesn't help us because the yield is so low, and they have a much higher false negative rate. In those areas where we have an outbreak or where community transmission rates are higher, that is when they might have more utility, and those are the areas that we're looking at more closely. So we really want to look at accessibility. It's helpful in areas where the gold standard PCR test is not as accessible. Where we need to make a decision right now, so rapidity, where quicker results will change what we're going to do on a day-to-day basis or on a right now basis. And the advantage they have is they're relatively low cost, the tests themselves, but they do continue to need to be done within a healthcare environment. They are a medical test, and they do need to have a quality assurance program, and we need to connect with public health for every positive that needs to be validated, and to be assured that we can follow up on anybody who tests positives. So these are the situations that we've been using now. We use them where they fill a gap, as I said, and where compliance with public health measures are ensured. They do not take the place of all of the public health measures that we need to have in place. And we still have a lot of questions about places where they are best used. Is it better? A couple of things that we have learned from both the pilots here and across Canada is that acceptability of having a test goes down over time. It's not comfortable or nice to have a swab, particularly in people who don't have any symptoms, on a periodic basis. And so we know that in the long-term care homes, for example, worker testing could not be more than about twice a week. And is it better to use a point-of-care test twice a week or the more accurate PCR test once a week? And those are the questions that we're still wrestling with, both here in BC and in provinces across the country. There's still a lot that we need to learn, but we are establishing a rapid point-of-care testing team with our BC CDC lab and the ministry, and partnering with our health authority, public health leads, but also with different settings across the province to see where we might use these best. And as we move into this time when we have increased immunization of people and we're moving into our post-pandemic opening up, we're looking at where we're going to, where there's a benefit for different industries to have point-of-care testing or these rapid tests as part of the opening up process. So these are industries where outbreaks are more likely, like our food processing industries, like some of the agriculture, the large industrial sites. And we are partnering with industry right now to see how those can work in the coming weeks and months. Which is all to say, these are challenging. We're learning as we go with testing, as we have with all the other aspects of this pandemic. And we now have a written out strategy that will be published on the BC CDC website, and we'll have links to it aligned with our statement later today. So with all that, I will summarize by saying, we are in a new place right now in the our COVID-19 pandemic. We're getting our regular supply of vaccines, and more vaccines are on the way. We know that the Johnson & Johnson vaccine is in for final review with Health Canada. We don't yet know when it might be available, but that will be another tool, another piece that we can add to our toolkit. We know that we have increasing protection in our most at-risk people, and that will increase dramatically starting again next week. But we've also had an uptick in new cases, and we've seen the rise of some of the more transmissible variants in our communities here, particularly in the Lower Mainland. And we need to follow those and monitor them carefully. We can't let these successes of these great vaccines that we have now be diminished by a surge in cases that will lead us to a third wave. We know that we are taking all of the public health actions of case management, contact tracing, isolation, testing, making sure that we are doing what we can to contain the transmission that we have right now. And that is going to be incredibly important. And I know these restrictions and closures in many parts of our society have been draining on all of us. And we all want to get back to our regular activities as soon as we can. We know that the transmissibility of this virus, or at least we've learned, that it has a seasonality to it. And here in BC, we're coming up to that season in April and in May. I'd like to assure everybody that we routinely, every day, but every week, review the measures that we are using to determine whether these restrictions are still needed, whether there are things that we can do now safely that we couldn't even a few weeks ago. And the work we do is ongoing. We have had a response that is a whole of province response, and everybody has been doing their part. And it's about using all of our tools through this next period of time until we have more people protected, until we have a handle on the transmission in our communities. And it is a whole new place that we are moving into very quickly. Brighter days are ahead. So let's continue to stay this course with our safety measures, staying small, staying local, so that we can get there even faster. And let's, of course, remember to continue to be kind and to be calm and to be safe.
Thank you very much, Dr. Henry. I wanted to start by expressing my condolences, those of the premiers, those of the governments, those of everyone in BC, to the families and friends and caregivers of the 4 people who've passed away in different parts of our province in the last 24 hours from COVID-19. That number, of course, is since the beginning of the pandemic is 1,376, and we think of the 4 families today and all of the families who've lost loved ones in this pandemic. It is an extraordinarily difficult time because of public health measures, in part because of the circumstances of the pandemic, to grieve in the way that we need and as human beings to grieve, and we are thinking and are with all of you today. I wanted to note in our acute care hospitals, we continue to have the ability and the capacity and the beds to absorb all of the demands on our acute care hospital system. There is our acute care capacity, or the occupancy rate, is 93.2% of base beds at present, which leaves 642 beds empty and able to take new patients as of today. And if you count the surge beds that we added for the pandemic, that number is 74.4%, or 3,053 beds. In critical care, occupancy rate is 82.1%. That leaves 95 critical care beds available. And when you add our critical care surge beds, that's 318 beds available. These levels of occupancy are somewhat higher than before, not because of an increase in COVID-19 cases, because obviously that number has come down since the beginning of January in acute care settings, but because of other demands on the healthcare system. Nonetheless, in general and frequently, prior to COVID-19, our healthcare system was running at more than 100%. So these are measures that can be managed. It should be said that there are currently 8 outbreaks in acute care, 5 of them in Fraser Health, which reflect ongoing COVID-19 transmission in communities, and those present all of our extraordinary healthcare teams across our acute care hospitals with real challenges. And I want to acknowledge their work. And obviously, as we look to immunize people, we're looking to take even more measures to keep acute care hospitals safe. Every Thursday, we publish on the BC CDC website an update on outbreaks in long-term care, assisted living, and independent living. You'll note from this past week to this week in long-term care, there's 6 outbreaks, 2 in Fraser Health, 2 in Interior Health, 1 in Northern Health, and 1 in Vancouver Island Health. That over the last week we had the 1 additional outbreak that was at Glacier View Lodge in Comox Courtney, and that involved 1 staff case, and that over the entire week we had 1 new resident case in long-term care in total in all our long-term care homes, and 3 staff cases. We did have some new independent living outbreaks over the last week, and I recommend people review that document on the BC CDC website. What it does indicate is the strength and the extraordinary work that has been done in vaccinating people in long-term care, in assisted living, and now over the beginning the last week or so and into next week, independent living, to keep people safe. The effectiveness of that was demonstrated in the data presented by Dr. Henry on Monday and Dr. Ballum on Monday, and is obviously a source of deep relief and indeed joy for people who have families and friends in long-term care, and us who've been working on this issue and are and remain extraordinarily concerned. And that, again, allows us to do something very important, something that we're working to prepare right now, which is to increase the ability and a return to some degree of normalcy. It won't be normal, but some greater degree of normalcy in our long-term care and assisted living homes in the coming weeks. I just wanted to note that next week we'll be providing full lists of immunization sites. You'll note, of course, that since the beginning of the pandemic, given that there have been pop-up clinics at all long-term care homes, at all assisted living homes, in communities, in rural and remote Indigenous communities, we've already had thousands of immunization sites bringing the vaccine to communities where people are and where our most vulnerable are. And that process will continue in the coming weeks and is continuing now. For example, in this past week, we've now immunized something close to 3,000 home support public home support patients, and many of those immunizations occurred in people's homes. So this is extraordinary work by our public health teams and work that we're very proud of. So I want to bring you up to date, as I do this day of the week, on our surgical renewal commitment. You'll know that since May 19th, we've delivered surgeries to more than 90% of those patients whose surgery was postponed due to COVID-19. That through our surgical commitment, renewal commitment, we said we would get more patients their surgeries faster, and we're doing just that. The total surgeries completed since the launching of our surgical renewal commitment on May 18th is 70,321 in Fraser Health, 49,103 in Interior Health, 15,032 in Northern Health, 62,992 in Vancouver Coastal Health, 55,034 in Vancouver Island Health, and 10,649 in the Provincial Health Services Authority. For the week of February the 15th to February the 21st, health authorities have verified their data, and the total number of surgeries completed in that week, which remember included a holiday day, was 6,146, which is 256 more surgeries than the same week last year, that during a pandemic, and that is an extraordinary achievement again by our staff, our surgical staff, our healthcare workers, everyone involved. I want to say as of today that 212,105 British Columbians have received their first dose of a COVID-19 vaccine. And with our commitment to get vaccine to 4.3 million British Columbians who want it, 4.93% of us have now had a shot, about 1 in 20. To each of us, the efforts of everyone involved in administering vaccines are a welcome boost, an essential encouragement to our continued use of the skills to stop the spread and our adherence to the guidance and orders that save lives. Our work to stop the spread goes hand in hand with the work of those getting us our shots, giving their efforts the greatest support and the best of chance of success in seeing us achieve the community immunity we need as quickly and as safely as possible. We are counting on each other. And as we head into another weekend after tomorrow, let's reinforce this bond. Let's continue to demonstrate the care for each other that has marked our journey so far. Let us stay, all of us, 100% all in our effort to stop the spread. It is as important now as it has ever been during this pandemic. Aujourd'hui, nous annonçons 564 nouveaux cas qui ont testé positifs pour COVID-19 pour un total de 82 473 cas en Colombie-Britannique. Nous sommes attristés d'annoncer 4 nouveaux décès liés au COVID-19 pour un total de 1376 décès en Colombie-Britannique. Nous offrons nos condoléances à tous ceux qui ont perdu leurs proches durant cette pandémie. Parmi l'ensemble des cas confirmés de COVID-19 en Colombie-Britannique, 248 personnes sont actuellement hospitalisées, dont 64 en soins intensifs. Merci beaucoup. Thank you very much. We're happy to take your questions.
Thank you, Minister. As a reminder to everybody on the phone line, please press *1 to enter the queue. You'll be limited to one question and one follow-up only. I would also ask that you please unmute your phones. You're not audible until your name is called. First question today is from Shannon Patterson, CTV.
Oh, hi. Thanks for taking my call, guys. You said that first responders will be offered the AstraZeneca vaccine starting this month. Are you worried some of them that are offered that vaccine will say no and opt to wait until they qualify for the other vaccines under the age criteria? We're seeing a lot of people reject AstraZeneca in Europe because the clinical trials obviously had lower efficacy rates than Pfizer and Moderna.
Yeah, and I think we need to, I think it's a really good point. You cannot compare the clinical trials that were done by AstraZeneca, that were done by Moderna, that were done by Pfizer. Both the messenger RNA vaccines, so Moderna and Pfizer, the clinical trials were done in different populations, in different places, and using different protocols. And the fact that they both had very high results was reassuring. The AstraZeneca one was done in a different time frame where there were more variant cases around. They were done in different populations using different protocols again. And we really need to go back and think. There was over 150 different vaccine candidates last summer that were all developing their clinical trial protocols to try and see if their vaccines were going to work. So far, we have 3 that are approved for use in Canada, but the clinical trials were all done at different time periods in different populations. And the one thing about the AstraZeneca trial was that when they recruited into the trial, they did it in several different countries. They had very few people that were over the age of 65 in that trial. So the restrictions on use that the recommended restrictions in some countries, including the NACI recommendations here in Canada, I will note that Health Canada has approved it for use in all adults. Based on real-world experience as well as the clinical trials. But the clinical trials data was limited in older people, and NACI recognized that. And so they said, we know it works really well in this younger adult age group, so focus on that. What we have been learning, and I mentioned that in my opening diatribe today, but we're learning as we go with this. It's rapid response research. It means that we take what we know today from the UK, and tomorrow we'll know more, and next week we'll know more, and we're going to know a whole lot more about how the vaccine works in the AstraZeneca vaccine works in older people from the UK within the next few weeks, because they have been using both vaccines, Pfizer and AstraZeneca, in all age groups, but starting with older people in the UK interchangeably. And we are seeing good response from both vaccines in the real world. But that data is still being compiled. It takes time for all of that to come together. And we will, absolutely expect we're going to see more information about how well it works in older people. And NACI will be revising the recommendations as appropriate when that information becomes available. I will also say that these vaccines are used interchangeably in the UK, and they work as effectively, both of them. With some of the trial data from AstraZeneca, the trials themselves were challenging, and the 2-dose efficacy that is being used, that Health Canada based the approval on, was about 60-some%. But if we look at the data and the different arms of the trial, they did a single dose arm. And the prevention, the effectiveness, the efficacy, so that's in the trials, we call it efficacy. In real life, we call it effectiveness. But in the clinical trial of this single dose, it was 87%, I believe it was, 85 or 87% effective after 12 weeks. And when they did the 2-dose one, the people who got their second dose 12 weeks or later also had much higher protection from that vaccine. So the bottom line, which the WHO with vaccine experts are saying, is around the world, these vaccines work. They all work. They're effective, they're safe. So take the vaccine that you're offered. And I would say that to everybody out there. The AstraZeneca vaccine works well. It has high levels of protection after 3 weeks. And we know that we may even find that it is effective for a longer period of time with a single dose, like the Johnson & Johnson vaccine. So the Johnson & Johnson and the AstraZeneca are both viral vector vaccines. So again, they're another new platform, similar to the messenger RNA vaccines are different, but they're the same type of platform. So we're learning more as we go. And yes, we will be coming out with a prioritization for people who are in our essential workers, people who can't work from home, first responders in the coming days. And the AstraZeneca will be the one that we'll focus on because it's fridge stable, which means we can be much more agile in how we're able to get it to people's workplaces and things like that. All of these vaccines are amazing, great vaccines. They're safe and they're effective.
Shannon, do you have a follow-up?
Yeah, a question for a colleague. Many families have been fighting to get essential visitor status. At one facility, families say there appeared to be a blanket policy of denying the designation to everyone. The Ombudsperson's office reviewed a complaint and found 25 out of the 100 residents there would have benefited from having an essential visitor. So does it concern you that some families were treated unfairly and denied essential visitor designation?
Yeah, it does absolutely concern me, and that is one of the reasons, working with the advice of the Ombudsperson's office, Mr. Chalk, we put in place a single provincial order and a single provincial guideline. And it is troubling to me when I hear those stories. There is a process that is outlined in those guidelines of where to go if you feel you've been inappropriately denied that essential visitor status. So that is important for people to know. It's on the website, it's linked to it on my website, the PHO website, with the order. And there is an appeals process. You can as well, if you feel there's an issue like this, go to the Ombudsperson. His office has a role to play as well, as does my office. But your first step is to go directly to the administrator of the facility that you're working in, and there is a time sensitive process that they must follow. I will say we have over 500 long-term care homes and additional assisted living facilities in this province, and so I cannot know what's happening in every single one of them, but our guidance is designed to be consistent and to err on the side of providing an essential visitor for everyone who asks for it.
Next question is from Richard Zisman, Global News.
Dr. Henry, can you give us some details on what clusters will be targeted with AstraZeneca? Are we talking regional or types of clusters, and how many AstraZeneca vaccines are we expecting to receive with this expiration date of the end of March, beginning of April?
Well, the second one, I don't know. These are all things that, as we, way back in December when we said it was changing every day, well, it's changing every day. We don't know yet. We understand that there's some proportion of the 500,000 doses that arrived that have an expiration of April 2nd and some that are much later in the month. So we don't have details on that yet. We don't have details of how much of which we'll be getting. There are a number of ongoing clusters right now. We can look at the data, and you can see that the rise in 7-day rolling average of cases, the outbreaks, the clusters we're seeing in communities are in the Lower Mainland particularly, and that's where some of the more recalcitrant outbreaks have been. Some of them are in food processing, some agricultural working. We're also looking, we've had some ongoing outbreaks in the north. So my public health team and the BC Immunization Committee are looking at where we can best stop these outbreaks that are ongoing in people who don't necessarily have the ability to effectively use personal protective equipment and barriers in their workplace. And food processing is the highest risk of those industries, and we've had ongoing outbreaks that affect large numbers of workers, and not only workers but the community. So people who are getting sick in a food processing plant in the Fraser Valley, many of them are lower paid workers who live in communal large settings, either communal settings or in multi-generational households, and the spillover into our communities that then is into other areas through transmission to family members. So those are the types of outbreaks that we can make a big difference on right away with added vaccine that we hope to get in next week. But the prioritization of that is with my public health leadership team right now.
This is from Minister Dix for a colleague. We're seeing rates of burnout from paramedics that are incredibly high. We've heard from one that said that 10 to 30 ambulances are down on a given night because of that burnout. What are you doing to address those concerns, and what do you say to British Columbians who may be underserved by paramedics because of the burnout that's happening from workers?
Can I say a word first, just to put a shout out to my colleagues who work in the BC Emergency Medical Services and our ambulance paramedics everywhere in this province, the community paramedicine program. It has been an incredibly challenging time for paramedics and for all first responders, but with both of the public health emergencies that we're dealing with. And I know it takes a toll on us physically, but also mentally and emotionally as well.
Richard, I think the work, as Dr. Henry has just said, of our ambulance paramedics has been truly extraordinary. In this time, we have 2 public health emergencies, as you know, on the ground for people in every region of the province for our ambulance paramedics. The impact of the overdose public health emergency has been significant and is a significant daily part of the lives of ambulance paramedics everywhere. And it has an impact even beyond the numbers of calls. We're not seeing an increase in general in the number of calls, but the overdose crisis has made a major qualitative difference in the lives of ambulance paramedics. As you know, we have added significant ambulance paramedics positions in the last 2 years across the province of British Columbia, including very significant additions in rural and remote areas during this pandemic to address the challenges of COVID-19 and the need often to get people to regional hospital centers more quickly. The significant number in the intervention of ambulance paramedics, for example, in communities such as Fort St. James, in the Cariboo and other regions, has been a sign of this, and we're obviously very concerned about that work, and we're working very actively with the Ambulance Paramedics Union, QP Local 873, the Ambulance Paramedics of BC, to ensure that we're addressing quality of life issues amongst ambulance paramedics. I believe I'll be meeting in the very near future with the President of the Union to discuss those ongoing issues. I think I would say that together with our ambulance paramedics, we were able to together negotiate a collective agreement, freely bargain at the bargaining table, which was an enormous achievement. And we've significantly increased the number of both ambulances, access to air ambulance, and the number of ambulance paramedics in BC, and expand the community paramedicine program. All those things we've been able to do. But the daily reality of life that you talk about in your question is real, and one that we're working with our ambulance paramedics to address, to assist, and to provide the kind of support necessary both to help people deal with the incredible stress of the job, but also to help people recover who've needed to take time away.
Prabjot Kalan, Omni.
Hi, thank you so much for taking my question. So the one local Sikh temple actually raised a concern on behalf of the community regarding the limit and how it's affecting the mental health of those who are unable to grieve the passing of the loved ones due to COVID restrictions. They can't visit to the hospital. They can't even attend whole family as a funeral, even not able to attend as a family the last prayers of the loved ones, which is very important for the Sikh culture. And they are asking for the increase the number of people to attend these funerals, especially the temple prayers, because the temple has a huge space. They can maintain the protocols as well.
No, and I hear that, and I do feel that deeply for many families around the province. It is the most challenging time, and funerals are those times of both grief and celebration of lives that is very challenging for us to keep small and to postpone. And I know for many different faith communities, there are different important rituals that are around death that need to be done. But I also know that there are ways that we can support people to do it safely through this most extraordinary of times, the global pandemic that we are all in. And we have seen heroic examples of that from different faith communities across this province, whether it's Sikh or Hindu or Muslim or Catholic or Indigenous ceremony. We need to find ways to do ceremonies that are so important to us as a community safely for a little bit longer. We will be there again, and we will need to find ways to make up for the loss of those important ceremonies in our lives for the last year.
I think many of my friends in the South Asian community, whether they're Sikh or Hindu or Muslim or other religions or Christian or other religions, have found this to be a particularly difficult time, as all people have in BC. A very dear friend of mine lost his father 2 weeks ago and held a memorial with 9 people in attendance, consistent with the rules, and spoke very movingly both about the power of that and the importance of that moment, but also the sense of loss at an event which undoubtedly hundreds of people would have otherwise attended, including myself. So people have been dealing with this throughout the pandemic, and we have to make a note of it, not just those who have passed away related to an infection of COVID-19, but everyone who's lost loved ones who hasn't been able to fully grieve or fully recognize that loss. And so that's something that all of us are going to have to think about doing at some point in the future when restrictions are reduced, find ways to come together to recognize, to celebrate the lives of the people that we've loved who have passed away. So we appreciate that. But I would say this as well. There are 568 cases today. The significant, even I believe the majority of those cases, overwhelming majority of those cases, at this time, it was different in January, but at this time, are in Metro Vancouver. Significant numbers of cases. About half of them, or a little more than half of them, in Fraser Health. But we have to continue to follow the measures and the guidance right now. And it's particularly important on gatherings. There are enormous numbers of important gatherings that people are not able to go ahead with right now, including sporting events, including religious ceremonies that are so important, such as weddings and funerals, not able to go ahead with in the same way that we would otherwise. Other events in communities, arts events. People often write me about the movie industry or about cinema and being able to go to a movie. And of course, many events that bring people together in our own homes. But we have to stick together to stop the spread right now. We simply have to do it. And that means that these sacrifices, which have been enormous, and which all of us, every single one of us, have felt personally in the last year, because I doubt there's a person in BC who hasn't lost someone close to them in some way in the past year, hasn't known someone, a family member or a friend or others that you're connected with, or a workmate or whoever, who have not been lost in the past year. So we know that this has been a loss that's been felt by everyone. We have to ask people in every community, especially and people of faith, and people such as you mentioned, the Sikh faith, are one of those groups. We have to be with one another right now in solidarity, remain apart as much as possible right now and consistent with the rules and the guidance of public health. It is so important right now as we start to vaccinate people, 5% at this time, 1 in 20 of those eligible to be vaccinated, and making progress every day as we do this to stop the spread and make sure that we save lives and save suffering, to save people from suffering across BC.
Prabjot, do you have a follow-up?
Yes, please. The latest poll suggests 60% Canadians suffering the mental health issue due to COVID, or some experts suggest we might see the mental health tsunami after this pandemic. So is there any take on that?
Yeah, and that is something that we've been watching very carefully as well. And we know from literature on other crises that a lot of it depends on the support that we get as a community. Resilience is really a community effect, more so even than an individual effect. Our ability to have our individual resilience is also dependent on our community. So that is a really important thing to remember that we know from previous crises. We also know that there is a sense of anxiety that comes with the uncertainty that we're living through, and that all of us are feeling it to some degree or the other. Some people are float above it, if you will, but many of us are feeling it intensely, and I'm particularly concerned about young people. Young people in their teenage and early 20s, because they have had the least ability to affect things, and their lives have been the most changed, and they feed or they have the anxieties that all of us as adults are feeling and projecting into the world as well. So, we need to pay attention to young people. We need to support them. We need to look to providing additional supports for the future for young people, because if you're one of the young people in my life who graduated from high school last year and didn't have a celebration, who had very limited job prospects because of what we were going through. University is a remote thing that you don't even get to connect during a period of time where social connection is so much a necessity in one's life. It's how you find your way in the world. So this is something that, as you can tell, I'm quite passionate about. We need to support mental health for all of us right now, but we need to look to the future for how do we build those things in place that allow particularly our young people to recover from this most traumatic year in that way. And we have been doing quite a lot of work on the societal impacts of this pandemic, and the societal consequences, not just of the virus, but of the measures we've put in place to deal with the virus. And we've been monitoring mental health issues as well. So we know that early on there was a lot of concern about mental health. We've had increased people phoning helplines, especially young people. We know that there's increased interpartner violence and violence against women that have been triggered through this process as well. But we also know that there are things that we can do that help diminish that, and that most people will recover in time if we have the right things in place. So this mental anxiety, depression, concern that we're going through now, we can recover from that, and most people will, if we're able to continue our sense of community and find those right supports for people. So yes, I'm very concerned, and we are looking at the impacts and what are the specific measures that we need to have to support every one of us in the next month to a year, because it's going to be a long time for this to play out as well.
Next question is from Marcella Bernardo, News 1130.
Hi, Dr. Henry and Minister Dix. Thank you again for taking my question today. First up, I know you've touched on this a bit about the approval of vaccines like AstraZeneca and possibly the Johnson & Johnson, but how far does that go to possibly moving your timeline up to immunize people that are younger in general? Like you mentioned that there are a lot of people in their 20s that are struggling right now. do you think that we will be able to move the timeline up sooner so that we'll see a lot of younger people being able to get at least their first dose over the summer?
Oh, I hope before the summer. Yes, absolutely. And we are looking at revising the timelines. We didn't have time to do that for the graphics for Monday, but with the new information. And as we have more vaccines, this is why we've been trying to focus on the what we knew was coming in, focusing on where we could make the most difference the soonest, and that's the age-based foundational program. But with these additional vaccines and our ability to be more flexible in how we use them, we need to address those people who have not been able to work from others, away from others at home, and they are also, we know from the data on cases, people who are more likely to be transmitting. So in terms of being able to reduce the effects of the virus and transmission in the community, targeting as much as we can to essential workers and to frontline first responders. That's going to help us reduce transmission in the community. So it does that dual effect. And our goal absolutely is to make sure that we, I like to, I don't know, maybe I'm too optimistic, but we're going to be in our post-pandemic world by the summer if things continue to go the way that we want them to. We know there's going to be snags, so I hesitate to say that. But I think it was Eisenhower said, no plan survives first contact with the enemy, but we are going to do our best, and we are going to make sure that young people have that experience. And I think by the summer we're going to be able to be doing a lot more of those connections that we need, that's going to help us get through the trauma that we've all experienced together.
Follow-up, Marcella?
I do, and I don't mean to be a Debbie Downer after what you just said, but with at least 16 schools in Fraser Health now recording at least one variant case, what extra measures are being considered to prevent the need for rapid response teams after the fact? Because we're seeing, at least 16 schools now that have variant cases recorded. What can be done to try to maybe preempt the need for rapid response teams going into schools?
You know what can be done? The most important thing is reducing transmission in the community. That's where people are getting sick and are getting infected, and in the school environment we have the exposures. And yes, it does mean that we are doing extra testing, particularly around the variants, because we are concerned about that increased transmissibility that we've seen elsewhere. I say that because I believe there's about 23 exposures in 23 schools that we've seen so far, and we have not had a lot of transmission. There's been 1 or 2 cases at most. I believe last I checked it was, I think there was 4 additional cases in 3 schools. So that, despite doing a ton of testing to be sure. So that's the good news. We're not seeing widely taking off transmission from these variant cases, but it's anxiety provoking, it's stressful for the public health teams, for the school communities, and yes, the best way to stop that is to reduce transmission in our communities so we don't have people in the school community, both the educators and students who become infected with the virus. I will say as well that we know the rates are higher in some communities than others, and I know that Fraser Health is working with particularly the Surrey School District to look at everything that they need to understand about how to make sure that the COVID safety plans are being adhered to support the communities there, and what options we might have.
We have time for one more question. For everyone listening, Dr. Henry and Minister Dix will release a statement this afternoon with the latest information on cases, hospitalizations, and outbreaks, which you can find at news.gov.bc.ca. For updated province-wide restrictions, visit gov.bc.ca/COVID restrictions. And for information about the province's orders and pandemic supports, visit gov.bc.ca/COVID-19. Last question today is from Tanya Fletcher, CBC.
Dr. Henry, just jumping off of Marcella's last question there, asking for a colleague if you could any detail more precisely about the variants of concern in schools. You mentioned there are 23 confirmed cases recorded at BC schools. I believe that's what you just said. Can you confirm that between 5 and 8% of the COVID cases in BC schools are now variants of concern?
No, it would not be that high. I don't know that that's that anyway. I'm sorry. I have to get back to you on that. The percent of variance of concern that we're seeing is hovering around 1% overall. And I know there was 23 schools that had an exposure over the last number of weeks since we've been testing with variants of concern. Having said that, there's not been very much transmission, as I mentioned.
Follow up, Tanya?
Please, thank you. Hoping you can outline as clearly as possible the plan to resume visits to long-term care homes now. You mentioned, I think Minister Dix mentioned more info in the coming weeks. We know most residents have been given the second dose, but some haven't. Can you explain how you'll be making decisions around easing long-term care home restrictions, the logistics of how and when, what you'll be basing it on, and will your schedule differ now given the 4-month interval versus before, and if so, how? And an answer in French would be great. Thanks.
No, I can't give you all of the details because we're still working on them. But, what we are learning, and this is the thing, as I mentioned, we know more this week than we did last week. We made the decisions we made because we have now seen, particularly in long-term care, that if you immunize everybody with 1 dose, you get to that level of protection that we thought we had to wait till a week after 2 doses to get. So what that means is you don't need that second dose before we can increase interactions in long-term care homes, that the residents themselves are protected enough from that single dose that we know we can use the second dose to protect others in the community now and provide a second dose when we have a better understanding of what the best interval is. So the protection level that we're seeing after the first dose in long-term care means across the board we can now step up that time to when we can have increased visits, when we can have more physical contact with our loved one in long-term care. And that will happen before the end of this month. We are working those details out. We still need to be cautious because in our community there is still virus being spread, and we know social visits are incredibly important for people in long-term care, and we can increase the access to social visits, but that needs to be done with appropriate PPE still, because we know that the protection was never perfect, but we also want to make sure that we're not introducing it into the environment where somebody who may not have had as good a response or may not have been able to be immunized can then be exposed, and visitors themselves can be exposed. So it won't be back yet to what we used to have prior to the pandemic where people could come and go freely, but it will be much more than what we had over the last few months, and there's more freedom for those who are protected themselves, so the residents, to be able to safely go out to medical appointments, to safely go have a visit with their families and come back and know that they're not going to be at risk for their whole community and care home. You have to say it in French.
En français, c'est bien. Oui, je pense la réponse c'est qu'on va le voir avant la fin de ce mois, c'est-à-dire le mois de mars. Nous n'avons pas changé notre intention à cause des changements sur la deuxième dose de cette semaine. Donc, on va continuer à travailler sur ces changements. Ce n'est pas un retour au normal précédent, mais cela va ouvrir beaucoup les opportunités des gens qui habitent dans des maisons de soins à long terme. Ces gens-là, de pouvoir, par exemple, aller en dehors de leur résidence pour visiter leur médecin, par exemple, ou d'autres gens dans la communauté, et aussi d'avoir plus de visites pour les gens dans ces centres. Donc, je pense qu'on va avoir une nouvelle politique d'ici la fin du mois, et je pense que cela va beaucoup améliorer la vie des gens qui y habitent. Il faut ajouter qu'on est allé nous avons eu beaucoup d'éclosions dans la province il y a un mois. c'est beaucoup réduit et je pense que tout le monde peut lire notre rapport sur les éclosions dans les centres de soins à long terme sur le site web du BCCDC. Merci beaucoup. Thank you very much. We'll see you on Monday.
Thank you for joining us.
And it could be the victim's own skin.